Good afternoon, everyone, and thank you for joining us for this PANCAP webinar on enhancing uptake of HIV services by male populations, the Kenyan experience. My name is Timothy Austin, and I'm the communications specialist within the PANCAP coordinating unit in Georgetown, Guyana, and I'm pleased to be your moderator for today's webinar. Let me extend a warm welcome to you on behalf of the partnership and PANCAP's director, Mr. Derek Springer, and our knowledge coordinator, Dr. Shanti Singh Anthony. PANCAP continues to serve as the knowledge hub for the region, and through this forum, we are pleased to share with you new knowledge and skills to build the capacity of our members and stakeholders. This PANCAP webinar is designed to provide knowledge on improving HIV services for the male population in our region. And before we start, I have a few housekeeping points to share with you. First of all, your mics are muted. If you have questions as the presentation progresses, please note them down in the sidebar that you'll see on your screen. Following the presentation, there will be a question and answer segment. Please type your questions in the comment section. And finally, the webinar will be recorded and shared on the PANCAP website or YouTube channel and social media platforms for the benefit of the greater partnership. Today, our facilitator is Dr. James Wagude. Dr. Wagude works with the Siaya County Referral Hospital within the Ministry of Health in Kenya. He is also the chair of the Nyanza-Western HIV Regional Technical Working Group under the National AIDS and STI Control Program. He holds a Bachelor of Medicine and Surgery, MBCHB, from the University of Nairobi, and a Master of Medicine in Internal Medicine from the University of Nairobi. He's a recipient of the Arthur Ashe HIV Fellowship from Well Medical College, Cornell University in New York, in the United States of America. He has attended HIV conferences by the European AIDS Clinical Society in France and the Institute of Tropical Medicine at Antwerp in Belgium. Dr. Wagude, thank you for joining us, and I know you have quite a lot to share with us this afternoon.
Thank you, Timothy, and a good and warm hello to everybody in Guyana under the PANCAP coordinating region. And it's my pleasure to be joining you this afternoon to discuss this interesting topic about enhancing uptake of HIV services by the male population we serve, and just sharing new experiences from here in Kenya, a country on the east of Africa and with a large burden of HIV. So I hope it will be an interesting session, and I look forward to getting feedback from you as we go through the presentation. So thank you so much for the kind introduction. I think we could start now. So as I said, I work in Kenya as a specialist physician in the Siaya County Hospital, and I'm technical advisor to the Care and Treatment Unit, the National AIDS and STI Control Program, and also chair a regional HIV clinical technical working group here in our region in Kenya. So this is a quick overview of what I'm going to talk about briefly. I will do an introduction, look at factors affecting uptake of services by men, data on HIV in the male population, and then talk about some intervention and outcomes using the examples that are shown, and then I'll summarize the presentation and give us enough time to discuss and have questions. So we do know that men have a clear advantages in society, economically, political, which still hold today. But it's interesting that men are still less likely, despite those advantages, than women to seek out healthcare services, to even go for an HIV test, or to initiate and adhere to HIV treatment compared to the women. And this is true, especially even in Africa and across our region. Men and boys living with HIV are 20% less likely than women and girls living with HIV to know the HIV status, and are 27% less likely to be accessing treatment. So the factors are that men have poorer health seeking and health maintaining behavior, and that's a challenge that we have to overcome. And that's one of the focus of our presentation today. We also know that poor patient retention that we find in our male populations will eventually undermine patient and program outcomes, including the achievement of sustained viral suppression and the reduction of HIV transmission that all our programs target to reach. And Men are also more likely than women to die of AIDS-related causes. In our region in sub-Saharan Africa, men accounted for 41% of people living with HIV. However, the same male population accounted for 53% of AIDS-related deaths in the year 2016, which means men disproportionately tend to die more than women when it comes to AIDS and HIV. So, just introducing where Kenya is, where I'm presenting from this evening. Kenya is on the east coast of Africa, surrounded by Uganda, Tanzania, Ethiopia, Somalia, and has a very high burden of HIV, one of the highest burdens in the world. Our adult prevalence in the year 2017 was 4.9%, with more women affected with 5.2% compared to men at 4.5. We have 1.5 million people living with HIV currently, and we have an average of 52,800 new infections year on year, and quite a majority occur in people aged less than 14 years. So we have an adolescent age group that's really affected. Our incidence to prevalence ratio is about 0.04, and in the last year, recorded year in 2017, 28,200 people died of AIDS-related causes, and this has come down from 53,000 in the year 2010. So the epidemic is actually improving, but we still haven't met a lot of our targets. So coming back to men, what are the factors that make men have difficulty? And that's why I refer to it as a blind spot. Our HIV services seem to have a blind spot when it comes to looking for men and getting men on board on treatment. So some of the things that we talk about that are unique to men is when you consider the men people living with HIV who also take up substance abuse, such as people who inject drugs, people who smoke, people who take alcohol and drug abuse. This is more likely to be men compared to women. Again, due to the nature of the interactions and the peer-to-peer influence, this tends to be predominantly more of men than in women. And again, if you look at the risk of having HIV compared to the general population, sex workers are 12 times more likely to have HIV, but men who have sex with men are 19 times as likely. And then people who use drugs, which again tends to be predominantly men, are 28 times more likely to have HIV compared to the general population. And again, when you look at transgender women, people who change sexes, again, 49 times higher risk of getting HIV compared to the general population. Men also have issues when it comes to our facilities. They tend to think most of our healthcare facilities, this is common in Africa, but it's all over the world, are geared towards women and children. So the messages are, especially about HIV, are geared about getting women and children and adolescents on board and on treatment and on prevention, but they feel left out, that these services are targeted towards the female audience and they don't feel in place. And there's also a stigma. They fear the stigma associated with coming for HIV services or even testing for HIV services. So there's always that group interaction that men always want to feel part of the group and not left out. And this matters more when it comes to discriminated communities like men who have sex with men and transgender populations. Financial issues again, and lack of finances and ability to go to even just be in tune with what men want. Men are more comfortable when services are geared around their occupation. They won't be comfortable when to come to the clinic during the daytime when they're supposed to be working, but they feel better accepting services that come to the community and use times when the men are more available to do the services such as HIV testing. We know that climates are changing, and this has an impact. The environment and migration to look for work. We see these factors every day when people migrate, move to the US, move to Europe, away from Africa, away from the Caribbean, looking for better resources and moving away from the climate-induced changes. And then again, as I showed you earlier, men are more likely to bear the burden of the disease. They're more likely to be sick, more likely to die, and they have a poorer health-seeking behavior. So all this adds up to that blind spot that our programs have done very well for women, but we have a blind spot when it comes to accessing men and their services. And this is even worse when it comes to our health facilities and institutions, because, like I said, men prefer flexible hours. They want to go to work, provide for their families, then come and access HIV services early in the morning before they go to work or late in the evening. But most of our facilities run on standard times, 8 to 5 or 8 or 9 to 6, and it's very hard for men to fit in within this time because that's the time they're supposed to be at the workforce. Facilities could be inconveniently located to the men, or some of the services are offered in places that have labels that men don't feel comfortable coming to, like services offered in the antenatal care or the mother-child services, MCH, mother-child health facility. They feel like that's targeted towards the female population and they don't feel comfortable coming for those facilities. Then men also get frustrated by booking systems which are difficult to understand and to use. They don't do well when there are delays when it comes to when they come to make an appointment and seeing a clinician. They don't like unpredictable waiting times because, again, they have to be at work, they have to look for work, so they want things to be done quickly and predictable so that the patient knows how long is he going to spend in your facility. Then another thing that a lot of the male clients have noted is that there's actually hardly any focus or engagement with their population in terms of campaigns about HIV testing, HIV treatment, or even on HIV prevention, such as PrEP. There's hardly any focus on men. The focus usually tends to be on women, on pregnant women, on women who have like commercial sex workers, but hardly any focus is done for men, and that actually tends to put them off. And these are the blind spots we have to think about and address when it comes to our patients who are men. So when you look at the burden of HIV and men, this just looks at a global picture first about the percentage of these groups. You can see sex workers globally would take for 3%, while majority would be the rest of the population, which does not include the 9% of people who inject drugs, the 18% who are gay men and men who have sex with men. Transgender women take 1%, and 19% are clients of sex workers and other sexual partners of key populations who tend to be men. So you can see the male population tends to be really quite a lot, even globally. And when it comes to East Africa, where I work, the same sense tends to be true. 6% are gay, and 8% are client of sex workers. So that's the male population. So we need to recognize that the male population is there, and we have to tailor our services to reach the gap that exists in these populations. Again, what I mentioned about mortality, if you remember, that men seem to be disproportionately affected. If you look at the first graph, this is the number of AIDS-related deaths by sex in sub-Saharan Africa from the 1990s to 2017. So you can see, yes, initially there was such a high number of deaths before we promoted access to ARVs. But as we have promoted access to ARVs and as the deaths have started dropping off, what you can see strikingly is that women are actually dying less, and the rates in men actually has overtaken the rates in women, despite men being less affected by HIV. So that tells you a lot. The deaths are really disproportionate in the male community. And if you look at the regions outside Africa, the graph tends to be that women are actually dying less. Sorry, the women are the red one. The women are actually dying less compared to men, and that has remained standard. So this just tends to show you that mortality with men is disproportionate, and we must really try to tailor our services to reach them before it's too late and they die. So what interventions can we talk about? The first one I'll talk about is HIV testing services and what works for men. Like I said, men tend to be creatures of habit. When they're at work, they prefer services that reach them at times when they are flexible and they're able to attend those services. So with the first graph, you can see a systematic review of studies published in Africa over 5 years showed that men kind of tend to favor services that are in the community. So home-based testing, mobile testing, that's flexible, campaign-based testing, or index testing of the partner. That's usually once you've tested the one person and you test the partner, tend to be preferred in terms of acceptance compared to our standard ways of voluntary counseling and testing and provider-initiated testing. So basically, the graph shows you community-based HIV testing achieves higher testing coverage than facility-based. And this community-based testing is really highly acceptable to our male clients in Africa. Why they prefer it is that it's flexible to their working hours. With our campaigns in Kenya having done what we even do called night testing, where we go door to door testing patients at night. When we go club testing, when we go to the nightclubs and the discos and actually offer testing. And also we've started trying to do our workplace outreach testing by offering testing at the workplace where men are usually. And that has actually been more popular and taken and reached a higher uptake than asking men to come to the facility for the traditional testing. These methods, especially the mobile testing and campaign-based testing, are preferred, especially by men who have sex with men and other key populations. And it's actually more popular and there's higher uptake when you integrate HIV testing in the community with testing for communicable diseases or non-communicable diseases. Like if you include testing and screening and treatment for diabetes, high blood pressure, and malaria, that has actually been noted to improve male uptake in quite a few areas in Kenya. So another thing that we've looked at that actually promotes male testing is our HIV testing services in the antenatal clinic. So the first graph shows you in Kenya, our PMTCT outcomes, what happened over 12 months. In 2016, a lot of our patients, 76% of the women clients were actually retained in care. And we used that to now look at how do we strategize to increase the population of the men that are in relationships with these PMTCT mothers. So we aim to increase the male involvement by doing two things. We tried to do couple testing at the facilities and promoting self-testing at home. So what we tried to do is basically we offered HIV testing services to the male partners of the pregnant women. And we noticed that when we do that, it increases the uptake by men, especially when we tailor it to tell the men that testing with your wife or your partner, female partner, will help protect your unborn child once you know your status. And that message was really taken positively. And the uptake by men was actually increased when we combined that testing by also screening for other health problems such as malaria, sickle cell in our part of Kenya is very common, and as syphilis as well. So promoting other testing as well seems to sell the message that we're not only doing HIV testing, but we can test you and screen you for a lot of other diseases, and that really promotes the uptake of testing by men. Now, we actually did a study in self-testing in antenatal care settings, where in the region where I work, around Kisumu in Kenya, 280 HIV negative women were recruited at two sites. One was facility and one was a mobile uptake area for commercial sex workers. The female participants were shown how to use oral fluid-based self-testing HIV tests, and then to consult to offer the self-testing to their male partners, and this was followed up over a period of 3 months. The outcomes were then compared to doing a standard antenatal care testing at the health facilities where the male partners were invited to come to the facility and do a test with their partner. So what we noticed in this study is that self-testing did actually promote uptake of HIV testing services, where those who actually used the self-testing method in this study were able to reach a coverage of 91% of the male partners in 3 months, compared to what we noticed was the 51% using the facility-based HIV testing services. So that's a dramatic increase in the uptake, and it shows that just asking a man even just to have a self-test at the house with his partner will actually promote uptake, rather than asking the man to find time and come to the facility and sit down with you. So that actually shows that self-testing is a method that we can use to promote uptake of HIV testing services in men. So something new we're also trying to do in addition to that is assisted partner notification services, where now this is where the healthcare workers, after testing a patient, now offer the index patient, the one who tests positive, whether it's a man or a woman, an opportunity to test all the sexual partners that the patient has had in the last couple of years. So this involves that we need you to name the sexual partners you've had in the last 1 year and document this in registers, and then reach out using their contacts and ask the people who are listed to come in and do an HIV test. One of the things we must do is promote trust by making sure that we explain confidentiality will be maintained. So the person called will not be told who has been tested and is positive, but will just be asked, would you be willing to come in for an HIV test? So this is something new, and we find that it has actually promoted uptake, because usually when women are tested in the antenatal care system, they're asked to go and kind of disclose the status and bring the male partners or the sexual partners on board for testing. Now, in this case, it's the healthcare workers who actually reach out and do the testing, and we found that this actually does promote uptake of testing by the male population. So this is something we're doing in Kenya, and we think it's really going to open up our services to the untapped male clients who have not come in before. Sorry. Next is also something we've been doing in our part of the country, in the Western Kenya, which is voluntary medical male circumcision. So we know this is a strategy that actually reduces the risk of heterosexual transmission of HIV from women to men by about 60%. And not only that, it also reduces the incidence of herpes simplex virus type 2 and human papilloma virus. So this is something we've done in Africa and also in our region in Nyanza. And gradually from 2010 to 2016, we've been promoting the uptake of circumcision by the male clients. And during the uptake of circumcision, one of the strategies we do is offering an HIV test as part of the strategy. And that has actually been seen to take it up really well, and men have actually responded well to it. One of the things that we've done also is to map it to our love of football in Africa. We've promoted coaches to talk about this to adolescents and male footballers to talk about the advantage of being circumcised and the need to know your status. And we link the love of the sport to actually knowing that it is good for you to know your status, and a real footballer and a real man would actually protect himself by going for an HIV test and going for circumcision. So that has been one of the strategies that has really worked, though we have not reached our targets yet, because we still have barriers like people feel shameful when it comes to still undergoing a procedure. There's also a rollback where people feel like culturally they have a gender role where this is against the culture, and there's actually sometimes a fight back that men in the culture here should not be circumcised. Then sometimes there's a lack of trust that the service provider will keep their names confidentiality, and that's something we're trying to overcome. And there's also an issue of fearing violation of privacy. And of course, again, since it's a surgical procedure, there's always a fear of having pain during the procedure. So now, something else that we've actually tried to do in terms of increasing uptake of treatment by men is doing something called test and treat. You know, the WHO in 2016, 2015 led the rollout of testing and treating as a viable way of reducing HIV transmission and putting patients on treatment to increase the lifespan. So one of our studies that happened in Kenya and also in our neighbor Uganda was the SEARCH study. Now in this study, we tried to focus on trying to put patients, identify those who are positive and put them on treatment, and also give them other messages that will help them to achieve viral suppression. So the study enrolled 7,000 residents who are 15 years and older from 16 rural communities in the 2 countries, and who were followed up for a period of about 2 years in total. What was done was measuring their serostatus and their plasma HIV RNA levels every year. All HIV positive patients who were picked up during the study were offered antiretrovirals, and this used a delivery model that was designed to reduce the inherent structural barriers that we find in our hospitals, including improving patient-clinician relationships and also enhancing patient knowledge and attitudes about HIV. So when we used the study and we tried to sell those messages and improved patient-clinician relationships, this study actually picked up that using that kind of approach, test and treat can actually increase viral suppression in men. And if you look at the baseline, there's actually quite a difference between at baseline between in viral suppression between men and women at the beginning of the study overall. That's 48% was suppressed of women were suppressed compared to 39% of men. When we followed them up over a year, 78% of women were suppressed and 70% of men were suppressed. So the gap started to narrow. And then in 2 years, while continuing the same messages, the gap had actually narrowed further. 82% of women were suppressed, but remarkably, 76% of men were also suppressed. And now the gap is only 6% compared to the beginning when it was as high as 9%. So if you remember, if I told you men are again more likely to drop out of services, less likely to come for appointments. So this study showed that with reducing structural barriers, and if you remember the barriers I talked about, these are the long waiting times, the uncertainty about how long the appointment would take, the issues of booking, when am I going to be booked, the issue of even just, is this a female clinic or is this a clinic where a man can come to and feel that his gender role is not being threatened? Those are the barriers that they're trying to remove. And this showed that if you actually look at the barriers of your services and remove that, improve your patient-clinician relationships, and give your clients, especially the male clients, knowledge and attitudes about HIV, you can actually increase viral suppression in men significantly. And that's one of the messages that should really be captured, that we can actually change behaviors of men, despite what I showed you by targeting them with specific messages and experiences in the clinic. So now in Kenya, something else that we've been trying to do that's been very important for us is differentiated care, differentiated service delivery. So differentiated care is basically trying to reduce the number of times people come to your facilities and providing the HIV care and treatment services in the community so that they don't have to keep coming back to your facility. This in Kenya has followed quite a process right from when WHO released it. And then in 2016 in our country, we launched our AIT guidelines, which talked about differentiated care model. And we actually introduced a practical handbook on differentiated care. And we talked about those newly initiated AIT. We categorized them into two groups, those who present well and those who present advanced in terms of differentiated care approach. If you present well, we can treat you differently. If you present advanced, there's some more routine test that we'll do for you. Then also that at that time that it was introduced the concept of stable and unstable people who live with HIV once you've been on ART for more than 1 year. If you're stable, which means your viral load is suppressed, you're not at high risk of adherence issues, like you're not a child, and then you're not pregnant, you're not having OIs like TB, and you have been showing signs of good adherence, such clients are eligible for coming to the facility maybe once in 6 months and actually getting their ARTs delivered to them in the community through community ART groups. This has developed pretty well in Kenya. We've rolled it out to all facilities and communities in Kenya. And by last year in January, we'd finished our toolkit. As you can see there, quite a lot of things. We have a differentiated care operational guide. We have healthcare worker training materials, and we have lay healthcare worker training materials as well. The lay healthcare workers are our community health volunteers who actually help us in delivering the ARVs and the care to the community, to the focal ART groups in the community. Last year in August 2018, we actually revised our differentiated care criteria, especially for advanced people who live with HIV, talking about the concept of low-level undetectable viral loads and low-level viremia. And that's basically viral loads between 400 and 1,000. We're still going to take you a bit more seriously than somebody who has a viral load less than HIV viral load less than 400, which we refer to as below detectable limits. So we also did some more tests that we could do for stable and unstable clients, including screening them for TB using the TB LAM approach. And so that's an update we did to our differentiated service delivery. Why am I talking about this? This is an effective way of delivering HIV treatment to our male population because of the barriers that sometimes they find when they come to our facilities, and they feel that they can't really get through these barriers in terms of relating to our healthcare workers. And remember that what I was talking about, the blind spots that we have. So in the county that I work in Siaya, we've been able to deliver the differentiated service delivery model. And we started doing this by having a demonstration project in February 2017. And this was based on our national guidelines in 2016. And we also used guidance from the 2017 operational guide. So you can see there's quite a process we followed. In February 2017, we sensitized the health management team in the county, and we agreed on a phased approach to the implementation of the services. We selected 25 health facilities for the project, and we chose the high volume facilities which had more than 500 people living with HIV, and those which had an EMR system which could really benefit us. In February 2017, we also identified and trained healthcare workers on the differentiated care project planning, and that was a one-day training. And then we started implementing it in the next month in March, where we scaled up patients through categorization at enrollment, and also identifying and managing people with living with HIV with advanced disease, and then also now after 1 year differentiating them into people who are stable and people who are unstable. This just shows what we do at our facilities. Patients go through the duty station, which is the records room and registration. If it's a new patient, we screen you for TB, stage you for WHO. We assess you specially to look out for opportunistic infections. And we also categorize you based on WHO staging. And we also, in addition to that, screen and manage you for non-communicable diseases and mental health illnesses. The tests that we do after you've gone through the clinician in the room include lab and X-ray tests like a CD4 test, a gene expert TB testing if you're coughing, cryptococcal antigen test if your CD4 is less than 200. We do a reflex CD4. We do a reflex cryptococcal antigen screen. The new thing we've added is TB LAM test, where we screen for TB using urine and look out for TB in that way. After you've done the investigations, now you go back to the clinical care, and the clinician determines your categorization into well or advanced, gives you Septrin, initiates you on ART, treats OI, and puts you on isoniazid preventing therapy, and assesses you for iris at each visit. You also go through another member of nutritionist, where you go through the nutritional assessment, counseling, and supplementation, and you also see the counselor on, because you're going to be test and treat. So we're going to counsel you on ART, the importance, how it works, and expected side effects. We're going to do adherence assessment and counseling at each visit, and link you to a peer educator identified for you with a weekly phone call to assess your progress. So at the beginning of this program, the pie chart shows what the enrollment were. 89% who were enrolled at that beginning were well, that's 4,000, while 478, that's 11%, were enrolled and classified as advanced HIV disease. So we can see what has happened 12 months later. So this is a 12-month cohort, and the main thing I'm trying to show you is that retention matters. Even if you're an advanced, we can retain you if we use the differentiated care approach. So the first pie chart shows those who are well, that is if you remember the previous chart, the 89%. At 12 months, how many were retained? 77% who are well were still retained, and 23% were not active of those who are well at enrollment. So high retention rate, and this is important because I'll come back to that. And now for the advanced people, those who are advanced when they were enrolled, if you remember the 11%, we're able to actually retain at 12 months 83% of them, and we only lost 17%. Remember, men, again, compared to women, are more likely to present advanced and also have higher mortality. So using differentiated care approach can actually tend to keep those men in treatment, even when they present sick at the beginning. So that's a very crucial point that I wanted to bring out. Using differentiated care can actually work and deliver retention in your services at the end. So that's a critical thing, and this is a demonstration that it actually does help. And it's interesting to note that we actually retained more patients who present advanced compared to those who are well, because obviously the ones who get well tend to drift out of care because they really don't see why they need to keep coming back to the facility. So that's something that you also have to deal with. Okay, so Something else in terms of retaining our patients on treatment, and especially the men, is trying to optimize their treatment. Pill burdens is something that can actually affect how we men especially view our services and will be able to cope with staying into treatment. And something we identified in our program in Kenya is trying to minimize the pill burden and the number of pills our patients take. For example, we decided last year in our last guidelines in 2018, that all adolescents and adults on above 15 years or above 35 kilos on first line regimens which are complicated should be optimized to friendlier regimens. So the only exception is that the current viral load should be less than detectable limit. And these regimens that we're targeting are patients on tenofovir, lamivudine, and efavirenz. That's efavirenz 600 milligrams. And that was basically the largest bulk of our patients. Patients on tenofovir, lamivudine, and nevirapine, which means they are taking two different tablets because tenofovir and lamivudine are combined, but nevirapine is separate. Those who are on zidovudine, lamivudine, nevirapine, those also on zidovudine, lamivudine, and efavirenz, and any male or female patient who is on lopinavir or atazanavir, a protease inhibitor, but on first line. The reasons for that could be that the patient initially was on efavirenz or nevirapine, but reacted and we needed to switch them to a protease inhibitor due to the side effects. So basically, those group of drugs tend to have common things. They have a high toxicity, especially for efavirenz and nevirapine, as well as a pill burden, and that's true for lopinavir or atazanavir, especially for lopinavir. So we're looking at that in terms of trying to minimize the pill burden and switching them to the following group of drugs. For men, and this is where men have it lucky in our program, the choice is very straightforward. They go to tenofovir, lamivudine, and dolutegravir, which is a fixed dose, once daily drug. It's very suppressive, will suppress you, we think, in 3 months and maintain you on that. We also has less side effects and toxicity compared to the regimens I've discussed before, and we don't tend to see a lot of mutations to the integrase inhibitor groups. So we tend to think it's a more robust regimen that will keep you suppressed for much longer. Now, unfortunately for women, the issues of dolutegravir that have cropped up from the studies in Mozambique in terms of fetal neural tube defects means that for now we tend to give our female patients tenofovir, lamivudine, and efavirenz 400 as their option for optimizing until we get more data on the issue of dolutegravir. So for our male patients, it has become very easy. They get a once a day fixed dose combination of tenofovir, lamivudine, and dolutegravir. And the uptake of this has been very, very positive in our programs, especially for adolescent boys and men, because they come asking for that once a day drug, which is simple to take. They can take at any time of day and night, and it doesn't give them any toxicity to worry about, whether they are people who work at night like security guards or people in very intense daytime jobs like engineers or manual laborers. So this is approach we've found that actually can keep our male patients on our treatment for much longer. So that should be the last, almost second last slide. So in summary, as I've discussed, strategies that we need to tailor to improve our male uptake of HIV services, whether in Guyana, in Kenya, in the Caribbean, in South America, has to be tailored to the region, to the country that the patients are in, to their needs as men, to their cultural and society pressures, and above all, those strategies have to be cost effective. But we do know we have to start somewhere. We cannot continue denying our blind spot, because we know that if we improve male uptake, that has a positive impression in improving the overall survival and in improving viral suppression. Last but not least, one of the biggest things that we must remember is that we should not sit somewhere and make policies for the male population without interacting with them. We need to engage with them meaningfully and ask them and find out what their priorities are that will help ameliorate the barriers that are there in terms of HIV testing, treatment, and retention on care. because without the input of our male populations, our strategies may not work, because the target of those strategies will always feel like the services leave them out and don't take their opinions, their beliefs, and their needs into account. So I hope that's something that, as we go forward, even in the Caribbean, even in Guyana, we'll be trying to incorporate more from our male patients living with HIV, in terms of policy, in terms of advocacy, even in terms of just having a meeting with them in our clinics and our facilities to hear what can we do to improve the experience within our HIV care system. And so we can use that to actually develop strategies that help keep them in care. So with that, I come to the end, and I really, really thank you for your participation, and I look forward to engaging with you on a short question and answer session before the end of the session. Thank you.
Thank you so much, Dr. Wagude. That I must commend you on a fantastic presentation. I know it has a lot of value, especially for our civil society organizations and especially for our national AIDS program managers. And I really want to thank you for investing the time. I know it's actually after 9 p.m. in Kenya where you are right now, so we want to thank you so much for investing in this webinar. I want to invite everyone now to send your questions, and you'll see the question box at the side of your screen. You'll be able to type your questions there, and I see quite a few questions coming in, especially from our partners in Suriname. We have quite a few participants from Suriname. I'm really grateful for that. And we have one from Lucien Govard, and Dr. Wagude, I'm going to just read a question to you.
Yes.
Lucien wants your opinion. He's saying that some programs have suggested using female counterparts to reach men. How much of a progressive strategy is this, as it is argued by some that this strategy advances a notion of adult females being made responsible for the health of adult males? So he's asking, do you think, is it too much of a burden on women? Is it fair to ask the women to be responsible for men coming to get tested for HIV? What's your opinion on that?
Thank you for the question. Thanks, Timothy. So that's a very interesting question. And yes, it might look like we are actually asking the women to help us reach out and get their partners, their sexual partners who are men, on board and come in for HIV testing. But one of the strategies that I talked about is self-testing, and where you could use the female partner, the one who has tested positive or even negative, to reach her male sexual partner and offer him as HIV self-testing at home. And compared to what we used to do, because even in our antenatal care clinics, we used to test the mothers who come in who are pregnant and ask them, could you ask your partner to come and also share in your test? That still puts a burden on the lady. And we found that when men are approached by their partner and it's sold to them that it's good for us to know our status in terms of our relationship, they are more receptive to that, and they don't tend to think that it is a demand that the women is being put on women. And when the women are counseled about it, they tend to view it as a positive step in knowing the status of the person they're in a relationship with. And so that has become something that actually tends to work. Yes, it does put a lot of pressure on the woman. That goes without saying. But unless we also ramp up our community activities where we do outreaches to the male at home, at the workplace, that should also go hand in hand in also trying to reach the partners. And so I don't think we should only put the burden on the female women we test. It should also be put on the men who come in for testing, that could you probably ask your partner, either male or female, to come in for a test, or if they are willing to do a self-test with you at home. And that's one of the strategies we must use. But I agree that if we're not going to put too much pressure on women, then community outreach programs of testing have to really be tailored to where the men are. Are they comfortable being reached at work? Are they comfortable being reached at home after hours, at night, in the evening? Are they comfortable being tested in the nightclubs, in the pubs where they're drinking? So that's one of the things we have to look at. And I think that's why we have to engage with the men in our country, find out to the men, even just by doing a questionnaire, do you mind when your partner comes to you at home and asks you to do an HIV test with her? Or would you prefer if a healthcare worker comes and knocks on your door and asks you to do a test? So I think, like I said, you have to tailor the approach to the country. What works in Kenya might not work culturally in Guyana, and that's very true.
Okay,
Thank
thank
you.
you so much. Thank you so much, Dr. Wagude. And thanks so much to Lucien Govard for that question. And we have another question coming from Suriname, one of our partners, Monique Holtian, and she's asking if you have any tips for male-friendly services for STIs, PEP and PrEP. I know you mentioned a few of those in your presentation. Do you want to give any final tips on male-friendly services for PrEP? And she's asking about STIs as well, and as well as PEP.
Okay, great question. Thank you. Thank you for the question. Now, tips. The tips I can give you also is what seems to have worked for us is finding what men are interested in and engaging them on that. Like I mentioned, we're using football. I think football is probably not, I don't know, I'm not sure about the Caribbean, but it's very popular in Africa. It's viewed as a way of getting out of poverty, and a lot of football stars are followed in Europe with a lot of attention. So it's a sport that really, really gears a lot of support from men, especially. So we've used that to reach out to men and used our football coaches and our trainers to reach out to the students they train, to the adolescents they train, to the young men they interact with, and advise them on doing voluntary male circumcision in terms of increasing uptake, and also going for STA testing as part of the HIV test. And as part of the VMMC I mentioned, you also get to do an HIV test and know your status. And it's important to keep yourself healthy, because the football coaches also sell to them that the people who succeed in Europe in football are those who keep themselves healthy despite the lifestyle, their riches, their money. They keep themselves healthy to keep playing their sport. So in Africa, you must also keep healthy by knowing your status. So that's one of the strategies. If what interests men, if men like gambling, because that's something that has taken revolutionized a lot of things in Africa, because a lot of men are gambling in sports, especially football, then we use gambling by trying to get a message through that when you're gambling, have you ever thought of an HIV test? Because gambling is also like compared to having an intercourse without knowing, without using a condom or without knowing your status. It's a form of a gamble. So we're trying to use things that men interact with. And that's why it's talked about going to clubs and pubs where men congregate in the evening and offering them a test in a group of friends. And the uptake to that has been surprisingly pretty good. The men will discuss in a group and say, yes, we're not scared. Today we'll all test and we'll all go into a room and do this testing, and we'll just do it as a for friends. So finding what works for men and what men are interested in, and finding the role models who can speak up for HIV and HIV testing and STI screening can actually work. That's one of the tips we've learned in Kenya. Because with men, you have to capture them when they're free, capture them when their role models are talking, and also use their opinion leaders. For example, I talked about testing at work. We couldn't go into testing at work without getting the support of the trade unions. So we had to engage the trade unions and sell them on the idea of HIV testing for their staff that will keep their staff healthier and free of disease. And once we had their support, we were now able to approach men in the offices and offer testing using peer educators in the offices. So I hope those few suggestions help, but I'm welcome to always talk about that later.
Thank you so much, Dr. Wagude. Those are some very clear examples. And again, thanks to Monique, Haltian from Suriname for that fantastic question. And we have another question from Martha Lucent, and she's asking if you have some experience to share about these kinds of services for key populations. So men who have sex with men, sex workers. She's asking, bringing the services directly to your key populations. Do you have any experience with that?
Thank you for the question. And yes, I work in two counties. I work in Siaya, but in Kisumu, where I am right now, we have a large population of men who have sex with men. And one of the strategies we employed is because we first engage them and ask them, what kind of HIV services is more acceptable to you as a community? Are you willing to come for HIV care services at a health facility? or do you want us to reach you at a certain drop-off zone and or a special club where we can drop off the services and give you a treatment? And when we engage them, the men actually said they face a lot of stigma and discrimination when they come to health facilities. A lot of our health workers are not trained in accepting and communicating to men who have sex with men. And so they usually feel the health facility is a very closed experience in terms of discrimination to them. So when we engage them, we actually set up mobile drop-off clinics where on every day of the week, like a Friday of the week, at a certain time in the afternoon, we'll go to a club, rent a space, and provide testing services and also pick up services for treatment, and also remove samples for viral load testing and CD4 testing and any test we need to do. They accepted these services better, and using their networks, they actually popularized the dates when we go to a certain club or a drop-off site for them. And we every time we kept coming back to that club on that day we have set up for the appointment, the numbers of people kept doubling and doubling until we had to look for a bigger room. But this shows that sometimes it's engaging them and asking them, where is the service going to be more friendly to you? How is it going to be more acceptable to you? And who should deliver this service to you? Because even them, they say, we've dealt with this person, they had an attitude, we could tell they were not accepting. So we suggest that maybe we can get somebody else who has an open attitude and does not us or judge us immediately when we come. So they even have a voice in saying, this healthcare worker does not seems to judge us immediately when we come. And these are the things that you need to pick up and solve as you try to give services to the men who have sex with men. The ideas, their input is very valuable, and just listening and taking that on board and forming a committee with them as you deliver services in the community tends to help such a lot, because they give you feedback, instant feedback on issues that crop up, and they have even numbers to call when you get into a crisis situation. And in terms of prep, delivering prep to them, that was the best way to do it, because in the first time they were not willing to come to the pharmacies to pick up prep. So the only way we could give the prep medications to them was through these drop-off points where we could meet them and they come and get the services and then come back in a month's time for more of the same. So interaction, feedback, and engagement is the way to go. And it must be positive on both sides with a give and take approach. And that is where you can start.
Thank you so much, Dr. Wagude. That was a fantastic illustration. We have quite a few questions coming in, and I think this is a clear indication that your presentation was quite good, because a lot of people are interested. And there's a question coming, I think it's from Dr. Rhonda Moore, and she's the National AIDS Program Manager for Guyana. We're so grateful that Dr. Moore is participating in our webinar. And she's asking, do you have any information on self-testing in countries where the suicide rates are high? And could you advise on what would be a good approach to introducing this in such cases? And again, this is coming from Dr. Rhonda Moore from Guyana.
Hello? Timothy, can you hear me?
Yes, did you hear the question?
Yes, I did. Thank you for the question. Great. So I've seen the data, and the question advised in communities where especially men, or there's a high, shouldn't just say men, high prevalence of depression and suicide. So self-testing as a strategy then has been raised a lot of questions. One thing I've noticed is when you do self-testing as a couple works better than when you do it on your own in such communities. That's one of the approaches I've seen. So self-testing on your own, usually when someone comes to a pharmacy and asks for HIV test, yes, we have not seen in Africa, despite some high prevalences of suicide, we have not seen any attributable risk to self-testing with suicide yet. But I do know in some communities it's a factor that you have to think of. And so that's a barrier I'm talking about. If you're going to add something like saying, can we put our men, or does anybody who wants to do self-testing go through a quick mental health assessment, that still puts a barrier again in terms of getting access to the testing services. But I still say that's a challenging question, and I think each region has to think about it carefully. Think about the impact of drug abuse and substance abuse, both of which can influence high rates of suicide and depression, and think carefully through how to implement self-testing in the background of that. But I would tell you from my experience in Kenya, self-testing actually works when you get through the fears and the initial drawbacks and consternation that people have about giving an HIV test to a certain group of people without any HIV person being there to help do the test. So that's something we have to really consider. It's really a fantastic question, and I'll see if I can get any data to support that. Thank you.
Thank you so much, Dr. Wagude. And of course, we could be able to share that information with Dr. Moore at a later date. And there's
Yes.
another question, and this is coming from Aristide. I hope I'm pronouncing the name correctly. And she's saying, thanks so much, Dr. James, for the presentation. And she wants to know what is the key factor to achieving success regarding index testing strategy. And she's saying this is a new approach in her country and there is no national policy concerning this strategy. But she wants to know what's the key factor to achieving success in index testing.
Okay. So that's, I believe, if I just wanted to confirm, index testing is where you test one patient and then follow up with that patient and now test the partners. I believe that's what you're referring to. If I'm not, please, I'm sorry about that. So I talked about the assistant partner notification. That's something new even we're doing in our country, because before in most of our services in Africa, one of the way we sold HIV testing was it's confidential and we're going to protect privacy and confidentiality, and we will not seek to test your immediate husband, your partner. But we're moving away from that and we're using index testing, you as the index to test other people that you've had interactions with. And so far it now means that the healthcare worker has to go out of their way to look for the contacts and talk to them, convince them to come for testing without betraying confidentiality and the privacy of the index person. So we have to do a lot of training, because you have to get people to understand that still confidentiality must still apply. You must also be able to invite and tell somebody that you may be at risk of HIV and you would like you to come in at risk of testing without scaring the patient away or the person you're talking to. So that's very important. And sometimes when this is done on phone, messages can be distorted. So communication is very key. And I think the main thing is investing in human resource and training, because I've seen this approach work very well in Europe and the US, where if someone is HIV positive, it behooves the healthcare worker who has tested them to immediately notify their sexual partners. But this is something that we need to really invest more in both in the Caribbean and in Africa, if we're going to succeed. But yes, it's also a strategy we're starting to use, but we need to invest a lot more in training, a lot more in communication, and a lot more in setting up the resources and contacting and the finances in reaching out to people through phone or whichever method. Thank you.
Thank you so much, Dr. Wagude. That was that was a clear illustration, and we want to thank Aristide. He sent that question on index testing, and we want to thank him for that question. We want to thank everyone who provided questions during the webinar, and I think we just have about a few minutes left. Any final remarks, Dr. James? Any final remarks that you want to leave with us as we bring the webinar to a close?
Yes, thank you, Timothy, and thank you, colleagues from Guyana. I had the pleasure of interacting with a lot of the colleagues from the Caribbean when I attended the IIS meeting in Haiti, and I realized that we share a lot of the similar issues with Sub-Saharan Africa and the Caribbean in terms of HIV testing, our lack of male involvement as in our HIV services, and trying to reach that untapped need and trying to fix those, what I talked about, the blind spots. And I will only tell you, it is through engagement and talking to the men, finding out what their needs are, what are their priorities, and what would make them accept to get on board with our services. That is how we'll meet them at the point of need and adjust our services to deliver. We've done a great job, even in the Caribbean, of reaching women, reaching children, reaching adolescents. Now we need to focus on the last mile, which is reaching our male clients. Thank you.
Thank you, Dr. Wagude. And thanks to everyone who provided questions during our question and answer segment. So thanks you so much, Dr. Wagude, for those final remarks.
Thank you.
And as I said before, this is some valuable information for, especially for civil society representatives, as well as our national AIDS program managers. This brings us to the end of our webinar, and you will receive a short survey. I encourage you to provide feedback on this webinar, and will help us to improve future webinars so we can better serve you. So on behalf of PANCAP, the director, Mr. Derek Springer, and all our participants, let me once again thank Dr. Wagude for investing in the webinar and sharing his knowledge and experience with the partnership. Thanks to all of our participants who have joined us today. And as a reminder, the webinar was recorded and will be posted on the PANCAP website, the PANCAP YouTube channel, and links will be posted on all our social media platforms. So please do join us at our next webinar. You will receive the announcement via email, and you can receive announcements from PANCAP by signing up on our Facebook page, or you can email us at pancap@caricom.org to receive any updates from us on future webinars. And finally, do stay engaged with the regional response to HIV. Visit our website, that's pancap.org, and follow us on social media. We are on Facebook and Twitter at pancap.org. Once again, thank you to Dr. Wagude, and thank you to all our participants, and we'll see you next time.
Thank you so much. Goodbye.